I have just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting and consented on behalf of Palmetto GBA. I just want to open the floor to our three speakers this afternoon. We have Dr. Matthew Goldberg, Dr. Clay Cockrell, and Dr. Alexander Witkowski.
Dr. Shinokatsikas, this is Dr. Goldberg speaking. Thank you for allowing us to join here at the open meeting. All right, so I'll begin here. First off, I just want to thank you for the opportunity to present during this MoIDX open meeting for the proposed LCD molecular assays for the diagnosis of cutaneous melanoma DL 39345. My name is Dr. Matthew Goldberg. I'm a board-certified dermatologist and dermatopathologist, and I'm assistant clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai. My relevant disclosure is that I'm the medical director for Castle Biosciences, where I'm a paid employee and stockholder. On this slide that's currently projected, for background, Castle Biosciences is a company working to transform patient management in oncology by developing molecular diagnostic tests that provide clinicians with actionable information that address key questions in disease states with high unmet clinical needs, specifically including the fields of cutaneous oncology and ocular oncology. Today, I'll be focusing on the two diagnostic ancillary gene expression profile tests, or GEP tests, MyPath Melanoma and DecisionDx DiffDx Melanoma, that I will refer to as MyPath and DiffDx during the presentation. Next slide, please. At a high level, Castle Biosciences agrees with this draft MoIDX foundational policy DL 39345 that replaces the test-specific MoIDX LCD L37923, providing coverage guidance for only MyPath. And it's important that this policy will continue to provide Medicare coverage for diagnostic ancillary GEP tests for primary cutaneous melanocytic neoplasms for which the diagnosis is equivocal or uncertain. The policy and associated billing and coding article designate that both MyPath and DiffDx have met coverage criteria according to this policy. Next slide, please. We agree with the MoIDX designation of both MyPath and DiffDx as GEP tests that have met the threshold of medical reasonableness and necessity for Medicare and are considered covered tests under this policy. In the draft LCD, MoIDX medical directors have appropriately reviewed the published evidence supporting the clinical validity and clinical utility of these assays and highlights how GEP testing provides a much-needed, objective, ancillary diagnostic test that can complement the other subjective tools available to pathologists such as immunohistochemistry, FISH, or second opinion consultation. It's also important to highlight that limitations of billing one GEP test for a single lesion is consistent with Castle Biosciences policy. Further, coverage in DL 39345 is appropriately limited to specimens of uncertain malignant potential in clinical scenarios when GEP results will influence important clinical management interventions. In the setting of this broad agreement with the draft LCD, Castle Biosciences is recommending one revision to the draft coverage guidance to include board-certified and board-eligible pathologists and dermatologists as these two additional types of clinicians see and manage patients with these types of lesions today. Restricting covered use of MyPath and DiffDx to board-certified and board-eligible dermatopathology-trained specialists inadvertently bars access to GEP testing for other board-certified subspecialists who can order GEP appropriately within the intended use of both assays. Next slide, please. The draft LCD appropriately recognizes the unmet clinical need addressed by GEP testing of ambiguous melanocytic neoplasms, and multiple studies shown here support that diagnostic ambiguity remains a significant challenge for those interpreting skin biopsies and determining appropriate treatment plans for patients with melanocytic neoplasms. This diagnostic ambiguity can lead to clinical management uncertainty over and under treatment and complex conversations with patients regarding treatment and follow-up. Next slide, please. This slide contains a graphic with many of the peer-reviewed published manuscripts that respectively support the clinical need, clinical validity, and clinical utility of MyPath and DiffDx, and the evidence supporting each test is strong and is appropriately referenced in the draft LCD. Next slide, please. At every stage, pathologists interpreting skin biopsies endeavor to correctly classify melanocytic lesion as a benign nevus versus malignant melanoma when reviewing melanocytic neoplasms. And GEP is correctly considered as an objective diagnostic ancillary test that can inform this distinction seen here on the right side of this figure. The draft LCD mentions the NCCN guidelines and inclusion of GEP testing in multiple guidelines and subspecialty appropriate use criteria based on the published evidence further supports these tests as medically reasonable and necessary for diagnostically equivocal melanocytic neoplasms. I'll add, mention in these types of guideline documents is not a prerequisite for coverage, but does reflect the strong evidence supporting GEP for these lesions. Next slide, please. The draft LCD also contains clear and appropriate language limiting GEP testing to primary cutaneous melanocytic neoplasms for which the diagnosis is equivocal or uncertain, and for which patients may be subjected to additional clinical interventions. This language, highlighted in the red box here, will help to ensure that lesions appropriate for GEP testing are in fact the lesions being tested and that align with the intended uses of both MyPath and DiffDx. Next slide, please. As I mentioned at the outset of these comments, Castle is in strong agreement with MoIDX draft LCD, but we recommend modifying the coverage guidance to include additional specialists who are also highly trained to appropriately order ancillary diagnostic GEP tests. From the LCD language itself, the stated purpose of GEP testing is to assist dermatopathologists to arrive at the correct diagnosis of melanoma versus non-melanoma when examining skin biopsies. However, there are other well-qualified specialists who currently diagnose primary cutaneous melanocytic neoplasms with equivocal or uncertain malignant potential. Specifically, anatomic pathologists routinely receive and diagnose skin biopsies, and in some instances, function as dermatopathologists in their care. Dermatologists also routinely integrate pathology reports into patient management plans, and in some instances also function as dermatopathologists in their review of slides. We believe that these clinicians should be able to submit MyPath or DiffDx orders that meet the Medicare criteria for medical reasonableness and necessity, as they're both highly trained specialists involved in diagnosis, management, and forming treatment decisions for patients with primary cutaneous melanocytic neoplasms with equivocal or uncertain malignant potential. These clinicians can determine from their practice experience which patients are appropriate for testing. And finally, based on current practice patterns, these clinicians are currently able to order and do order other diagnostic ancillary tests. Next slide, please. The schematic displayed on this slide depicts the process of clinical pathologic correlation, or CPC, that essentially is consolidating the dermatopathologist and treating dermatologist's impression of a clinical lesion into a clinical diagnosis to ensure that the final pathology report makes sense within the clinical context of the patient being treated, and so that it is most useful for patient care. This process highlights 2 points in a patient's journey where diagnostic GEP can aid in achieving clinical pathologic correlation and accurate diagnosis. First, in the interpretation of ambiguous histopathology by the pathologist reviewing the slides under a microscope, and second, in rendering a clinical diagnosis as the treating clinician incorporates the histologic diagnosis in the pathology report with other clinical information to establish the patient management plans that follow. Importantly, different providers lead these 2 important diagnostic steps, and GEP can be incorporated by both the treating pathologist who provides the diagnostic interpretation and the treating clinician who incorporates the pathology report into actionable management plan. Taking a step back for a second, dermatopathologists are not operating alone in their role to sign out challenging melanocytic neoplasms, and there's clear collaboration between the clinician treating the patient and the pathologist interpreting the patient's skin biopsy to arrive at clinical pathologic correlation that ultimately informs patient management decisions such as additional surgeries and or sentinel lymph node biopsy. So for the next several slides, I'll walk through the rationale to aid pathologists and dermatologists as covered ordering clinicians for GEP testing in melanocytic neoplasms. Next slide, please. So first I'll discuss anatomic pathologists, and you can move ahead to the next slide again. Next slide, please. So the clinical utility evidence cited in the draft LCD demonstrates clinical utility for dermatopathologists, and while the majority of skin biopsies are interpreted by dermatopathologists, across the country there are anatomic pathologists who regularly interpret skin biopsies and who can order other relevant ancillary tests such as immunohistochemistry, FISH, etc. There are clearly regional variations in the number of dermatopathologists available to a particular community or group of patients. For example, rural areas have access to fewer dermatopathologists than do urban centers, and some practices have established referral patterns that may or may not include dermatopathologists. But the main point here is that there are pathologists who have developed significant expertise in interpreting skin biopsies, but who did not ever complete formal fellowship training in dermatopathology. So when a pathologist is reviewing and signing out cases for ambiguous or equivocal melanocytic neoplasms, in this capacity, these pathologists are essentially functioning as dermatopathologists. And as such, the published clinical utility of GEP in ambiguous melanocytic lesions for dermatopathologists logically applies to such a pathologist working in the same capacity within established clinical workflows in their region. Next slide, please. The figure on this slide maps out the process of clinical pathologic correlation again, and the white plus sign is located at the step where the pathologic interpretation takes place. And this is where dermatopathologists and pathologists today work to interpret skin biopsies and where they can order diagnostic ancillary testing such as GEP for equivocal melanocytic neoplasms. However, the LCD doesn't fully reflect this real-world workflow due to the fact that pathologists are not listed as covered ordering clinicians. So given the shared role of reviewing and interpreting skin biopsies, we support the inclusion of board-certified and board-eligible anatomic pathologists, as well as board-certified and board-eligible dermatopathologists as ordering clinicians for GEP testing in the final LCD. Next slide, please. And switching gears now to discuss the inclusion of dermatologists as ordering clinicians for GEP testing, we'll move to the next slide again. Going back to the clinical utility data cited by the LCD, there's published evidence that demonstrates clinical utility of both MyPath and DiffDx for dermatopathologists as well as dermatologists. Multiple peer-reviewed publications show treating clinicians can safely perform fewer re-excisions when equipped with a benign GEP result, which supports clinical utility for treating dermatologists by reducing unnecessary re-excisions of benign melanocytic neoplasms for the benefit of patient care. Next slide, please. Returning again to this schematic here of the clinical pathologic correlation process, here the white plus symbol corresponds to where treating clinicians are closely involved with establishing the clinical diagnosis, as dermatologists are central members of the diagnostic team and are responsible for integrating pathology reports into clinical diagnoses that subsequently inform management decisions. For example, a treating dermatologist may be the provider that first recognizes the clinical need for more diagnostic clarity, but this treating clinician may work with a pathologist who is either unfamiliar with or is a late adopter of molecular diagnostics for ambiguous melanocytic neoplasms. As the treating dermatologist is ultimately responsible for this clinical diagnosis and planning a re-excision versus forgoing a re-excision for a particular lesion, it stands to reason that these treating dermatologists should be able to have diagnostic GEP orders covered by Medicare. There's a second white plus sign above in the location where the plus sign was positioned in the previous slide. And this is because board certified and board eligible dermatologists are also trained to be able to interpret their own skin biopsies. And so it's possible that a treating dermatologist would therefore be in a position to complete a pathology report for a particular lesion, order other ancillary tests to best define the lesion. And when dermatologists are essentially functioning as dermatopathologists, we believe that they should be able to have GEP orders covered by Medicare as well. Next slide, please. So to summarize the past 7 slides, Castle Biosciences is supportive of a minor revision to the draft LCD because board-certified and board-eligible dermatopathologists, pathologists, and dermatologists are all skilled treating clinicians who should have access to ancillary diagnostic GEP testing to improve diagnosis and management decisions for Medicare beneficiaries. Fundamentally, Castle does not believe that if a patient has a lesion interpreted by a non-dermatopathologist, that they should be restricted from covered GEP testing. And limiting coverage for both tests to dermatopathologists alone will have unintended consequences that could include potential delays in diagnosis and treatment, equivocal diagnosis being signed out with unnecessary excision recommendations or significant potential for missed melanomas, and potential unnecessary subjective consultations if referral patterns are shifted based on provider inability to submit covered testing. It's important to keep in mind that the appropriate clinical requirements for lesions suited to diagnostic ancillary testing that are articulated in the coverage guidance in the draft LCD would serve to protect against inappropriate testing. And as such, adding pathologists and dermatologists to the LCD is beneficial for patients and will support appropriate testing. Next slide, please. So in conclusion, Castle Biosciences supports this draft foundational LCD DL 39345 and the inclusion and coverage of both MyPath and DiffDx and the policy based on the comprehensive literature review and high level of published evidence supporting these objective diagnostic tests. The draft LCD's limitations of billing one GEP test for a single lesion are consistent with Castle Biosciences policy, and coverage in DL 39345 is appropriately limited to specimens of uncertain malignant potential and clinical scenarios where GEP results will influence important clinical management interventions. We do recommend treating board-certified and board-eligible pathologists and dermatologists as covered ordering clinicians in the final LCD, as these specialists currently diagnose and manage patients with equivocal melanocytic neoplasms, and this reality is not reflected in the draft policy, and restricting covered orders to only dermatopathologists inadvertently bars access to GEP testing to these providers. It's again important to emphasize that the draft LCD coverage guidance on specimen inclusion and intended use language already restrict use of this test to specialists capable of determining when testing is appropriate. And so overall, Castle supports the draft LCD that establishes a foundational policy where both MyPath and DiffDx have met coverage criteria according to the LCD. The single modification proposed in these comments is the addition of board-certified and board-eligible pathologists and dermatologists as treating clinicians who can also order covered GEP tests, in addition to the currently listed board-certified and board-eligible dermatopathologists. Castle believes that the conclusion of these two additional specialists will support appropriate testing, and specific text suggestions will follow in our written comments prior to the close of the open comment period. In that comment, we'll also submit examples of LCDs that have less narrow restrictions on the ordering subspecialty, which could be seen as instructive guideposts to allow for the entire treatment team that manages patients with these equivocal or ambiguous melanocytic neoplasms, meaning the dermatopathologists, pathologists, and treating dermatologists to be able to order MyPath and DiffDx as covered tests. So with that, thank you for the opportunity to present once again during the open meeting, and I'll end there for any questions.
Thank you, Dr. Goldberg. With that, we will continue with the next presentation from Dr. Cockrell.
Well, thank you very much for allowing me the opportunity to present. I'm going to say a lot of the same sort of things that Dr. Goldberg just said. I am a consultant for Castle Biosciences. I'm not receiving any compensation for the presentation today. And as opposed to Dr. Goldberg, I'm actually a practicing dermatopathologist. I'm using this test pretty much daily in my practice. And basically, I'm in agreement that the LCD is a good one. This is something that does allow Medicare beneficiaries access to the testing, which I think is a very positive thing. However, I do think that there may be some limited situations where it's probably beneficial to have non-dermatopathologists have the ability to do this, because basically, we're not the only ones that deal with these lesions in the real world. So basically, I guess the question is, why shouldn't anyone who deals with these lesions, and this is a small subset of the universe of pigmented lesions that we deal with, by the way, the vast majority of lesions that we see are just easily diagnosed as melanoma or as benign nevi. There's a small subset that are more equivocal, and that these ambiguous ones that really require this type of testing. And currently, these individuals have access to other types of tests, people that are doing this other than board-certified, board-eligible dermatopathologists, but they're not really in this specific LCD would not be covered for using a better test, if you will. And so we really think that maybe they should have the opportunity to be able to order the test if possible. And just like Dr. Goldberg said, these tests are more objective than the current tests that are kind of routinely available, such as fluorescence in situ hybridization, which requires a screening by a technician, and then those slides are then presented to the pathologist. And they're not really as objective in that situation. We get to see what the tech sort of identified, and sometimes is coming from a third party. It's not even coming from the physician himself. But this test is more objective. Basically, the tissue is submitted for analysis, and there's actually an expression profile that says whether the lesion is more likely to be benign or malignant. And so it's really a better objective test. There are two tests available currently that are being used commercially. One is the MyPath test. And again, you see that in this slide, it demonstrates approximately 23 genes are analyzed. It comes up with a benign or malignant or an indeterminate zone. So again, it requires the clinician to take the information, to interpret it, and then incorporate it into the report, coupled with a histologic evaluation. And then the DiffDx test, which is looks at 35 genes. These are different genes, again, giving a similar type of report. And the two tests are complementary. Often one test will be performed and then the other test is then reflexed into the test. So these are two tests, and they're used together to come up with the more accurate information for rendering a diagnosis in these ambiguous lesions. And these have been validated by many different studies. The clinical validity has been evaluated. I won't necessarily go through these various studies with you. The clinical validity and utility both have been validated for both of the two tests. So there's good data to show that these tests work. They're being used in clinical practice today. And currently, as I said before, I'm using them literally every single day in my practice. The national organizations also now are recognizing the utility of these tests as well. And again, I'll just point out, these are for the ambiguous melanocytic lesions. These are the tough situations where we see maybe the differential diagnosis between an unusual atypical Spitz tumor in melanoma, or maybe an unusual lesion that may be a very atypical dysplastic nevus versus a melanoma, that the excision of that lesion would be different. And especially in an individual of a relatively young age, where it really makes a significant amount of difference. But also it's very important in the Medicare population as well, because we see a number of these, I'd say most common pigmented lesions that are possible melanomas arise in that setting. So this is something that's really quite important for Medicare beneficiaries as well. And these three organizations all recognize GEP as an important testing. Now, Dr. Goldberg mentioned that me being a board certified dermatopathologist, I'm dealing with these lesions every day and many times a day. But there are settings where there are people who are not board certified or board eligible who may have a special expertise in this, or maybe in a setting where they really don't have access to a board certified, board eligible dermatopathologist, and the only access might be to send it in consultation. And while that's reasonably valuable in a lot of situations, once I get a case in consultation, I may still say, well, this is still ambiguous. And so then I'm going to order the test at that point. So if the clinician back at the sort of before they send it to me has looked at it, maybe they've consulted with the dermatologist, they order the test, it's still ambiguous, they send it to me, I can then take that information that's submitted to me and integrate it at that point and come up with the most accurate diagnosis for them. So having them have the ability to use it in this limited situation, in this relatively small number of cases, I don't think it really puts the test at risk of being overutilized. These clinicians, there are very few of them that really feel super comfortable at diagnosing these ambiguous lesions just on their own. The ones that they do would like to have all the tools available to them to make the most accurate diagnosis they can. So I think that as we open this up and allow these relatively limited situations where they can order it in a rural setting or a setting where they really don't have access to a consultant dermatopathologist, it's not going to really sort of open the floodgates, if you will, to the overutilization of a test like this. And there are a number of dermatologists also who are dermatologic oncologists who see these patients, and maybe they've gotten an ambiguous diagnosis from a pathologist, and they say, well, wait a minute, if we could get this test done, we could get a more accurate diagnosis right now. Maybe they see the patient, maybe they really think it's a melanoma, they don't have a diagnosis of one. Getting something like this test available to them just at the local level, that can solve the problem relatively easily, and it doesn't really have to be sent off for a third-party consultation, which adds to the cost. So there are ways that this can be used in an appropriate setting where you don't really have just a board-certified, board-eligible dermatopathologist on site. Here's a good example of where this actually happened in our practice not too long ago. This was a 69-year-old gentleman who came in with an unusual lesion to a dermatologist. Was submitted as just rule out atypical lesion. They really weren't sure what it was. The histology showed an unusual atypical lesion. They didn't order the test on it, and the dermatologist said, well, this test is available. Why don't we get it? They did get the test on it. The result did come back that favored the diagnosis of a malignancy. That allowed the diagnosis to be made of melanoma unequivocally. The patient then underwent an appropriate surgical procedure at that time. So that was a good example of where the test was used in that setting to come up with an accurate diagnosis. It was dealt with at the local level. It didn't really require secondary opinion or anything like that. So it does show how this can be helpful for Medicare beneficiaries, this situation. So the value of these tests in summary is very well proven. It's well recognized. It's being used daily in practice. And I think coverage for this in the Medicare situation, certainly it's something we're very glad that we have available to us. But I think in a situation where we have the appropriate setting, it's reasonable to allow non-board certified, board eligible dermatologists and pathologists to use this test. And again, this is a relatively limited number of cases. The number of these lesions that we see in the setting of all the pigmented lesions that we see to rule out melanoma is relatively small. So we think it's something that can be used in a reasonable fashion if this is allowed to be included in the LCD. I'll be happy to answer any questions if anybody has those. And thank you very much for allowing me to present today.
Okay, great. Thanks for that, Dr. Rockrell. We look forward to you rejoining the session in a moment. With that, it looks like we have Dr. Witkowski's slides up. And when you're ready, please go ahead and begin your presentation.
Excellent. Thank you very much for the opportunity to speak to everybody today. My name is Alexander Witkowski, and I'm a practicing dermatologist in Portland, Oregon, at the Oregon Health and Sciences University Department of Dermatology, also the co-director of the Skin Imaging and Technology Center here at our department. I'm very familiar with this test. I'm using it several times per week. If you can please advance to the next slide. These are my current disclosures, and today I'm not being paid to participate in this meeting. Next slide, please. So I'm speaking here today in regard to the draft LCD MoIDX, Molecular Assays for Diagnosis of Cutaneous Melanoma, the DL39345. I want to start by saying that I fundamentally agree with the position that both of these tests, the 23 GEP and the 35 GEP test, commercially known as MyPath and DecisionDx DiffDx, should be available for Medicare beneficiaries under a single LCD. I do think that the draft policy establishes appropriate coverage for these two GEP tests broadly, but I am here specifically today because I have a single refinement or recommendation that I believe MoIDX should consider as this draft policy moves towards a final LCD. I do believe that dermatologists are inadvertently left out of the current wording of this draft policy, and I believe that this can be refined for the reason that dermatologists are the primary point of care and the experts for diagnosis and treatment of melanocytic neoplasms. I'm not advocating that every dermatologist should order these tests, but I do believe that dermatologists like myself who have a specialty focus on managing patients with challenging melanocytic neoplasms should be able to be engaged with the decision to order these GEP tests. This should certainly include dermatologists who use tools such as dermoscopy or tools such as reflectance confocal microscopy, and I will give an example in today's talk. Dermatologists as a whole work closely with dermatopathology and our pathology colleagues, but we are ultimately responsible for the clinical diagnosis and derive significant utility from objective GEP tests that may benefit our patients. This describes my particular practice on a daily basis. There are those other dermatologists who perform the professional component of the diagnosis, and those are my colleagues who actually are dermatologists, but they read their own pathology slides and then order other relevant ancillary tests as they see appropriate in that particular context and setting. In fact, CMS does reimburse dermatologists for this professional component of reading slides, and I think that it stands to reason that if a clinician can be covered to read slides and order other diagnostic ancillary tests, that they should be allowed to order GEP tests for the 23 and 35 gene test. The bottom line is that both dermatopathologists and dermatology treating clinicians should be able to order these tests and are capable of determining which patient will benefit from testing and then when this test is medically reasonable and then of course necessary for the patient. If you can advance to the next slide, please. So on this slide, you can see what I call the armament of tools that I'm using on a daily basis. And so everything on the left-hand side of the yellow line are non-invasive tools that are pre-biopsy, and then where the actual 23 and 35 GEP tests come into play after the skin lesions are biopsied. So you can see here tools such as dermoscopy, a 2 GEP adhesive patch, that's an in vivo test, and some other cases, confocal microscopy is being used around the United States, especially in highly specialized centers like our own. These tools allow me to evaluate the lesion before the decision of the biopsy has been made. I, as the expert, utilize these tools to choose. I use these tools to choose when I should be biopsying and when it is necessary to perform a shave or an excisional biopsy and help me to provide precision medicine to my patients. After the biopsy is done and a specimen is sent to pathology, this is where these particular tests we're discussing today, so the 23 and 35 GEP tests, can be ordered to guide the correct and final diagnosis of a melanoma versus a nevus by the interpreting pathologist. I believe that the need of these tests can be appropriately identified by the dermatology treating clinician, such as myself, after an equivocal or uncertain biopsy report is rendered for a patient, something I called a critical mismatch. And that specifically is where I have a very high concern for melanoma based on dermoscopic features that are very apparent and combined potentially with confocal. And then we have a critical mismatch with the initial result from the pathologist, potentially due to sampling bias. If you could please advance to the next slide. So advanced in vivo imaging tools may aid in pre-biopsy decision-making. However, of course, there is a broad consensus that advanced imaging does not benefit biopsy decision-making in lesions with a very clear clinical diagnosis, as you can see here. In these photos, I do not need a dermatoscope or an adhesive patch test or a confocal microscope to test, because the diagnosis of a benign congenital nevus is very clear on the left-hand side, and then a diagnosis of an invasive melanoma is also clear on the right photo. If you can advance the slide, please. So on the contrary, there is also a broad consensus that advanced imaging can benefit biopsy decision-making in lesions with equivocal or uncertain clinical diagnostic criteria. So in lesions such as the ones presented here, with in these two photos, additional imaging modalities such as dermoscopy and confocal can be beneficial to inform decision-making around the need to perform a biopsy. As a dermatologist, I am trained to know when these ancillary clinical decision-making tools are appropriate to use and when they're not appropriate to use. If you can advance to the next slide, please. So I put this into a schematic. You can see this figure shows how dermatologists use clinical tools to evaluate melanocytic neoplasms before biopsy. And then on the right-hand side of this yellow bar, dermatopathologists, pathologists, and dermatologists are all involved in the interpretation of subsequent skin biopsy and unpacking the clinical treatment plan that follows the receipt of the final pathology report in order to inform the management decisions for patients with equivocal or uncertain melanocytic neoplasms. But importantly for this particular presentation, even though derms, dermpaths, and pathologists are all involved in these decisions, the current LCD DL 39345 is only allowing dermatopathologists to utilize this particular testing for uncertain equivocal melanocytic neoplasms. Please advance to the next slide. So here I'm giving comment about the LCD, which appropriately covers dermatopathologists ordering both 23 and 35 GEP tests. But I do think that there's an opportunity for consideration to allow other skin cancer specialists to also have access, to have the ability to order these tests when there is significant clinical ambiguity. This particular ambiguity occurs when the diagnosis between a melanoma and non-melanoma remains uncertain or equivocal after the initial pathology review, which could lead to potential overtreatment or undertreatment by the ultimate person who's responsible for the patient management, which is actually the dermatologist or the dermatology provider. Benign melanocytic neoplasms, those mild or moderately dysplastic, do not necessitate re-excision. And clinical ambiguity frequently results in patients managed with surgical re-excision for non-melanomas because the treating dermatologist has some significant concern for missing a malignant melanoma. So this is why we see that 65% of physicians re-excising mildly or moderately dysplastic nevi in published studies like the one presented here from 2014. This compares with the literature published and properly cited in the draft LCD that does show that GEP testing with 23 and 35 GEP can reduce surgical management decisions, again, to avoid unnecessary re-excisions, for which I've noticed that my patients are very gracious, as long as we're providing a high precision care to them. And this is when dermatology clinicians obtain a benign or a negative, benign, which is in fact a negative gene expression profile result when using this 23 and 35 gene test. Accurate diagnosis has inherent clinical utility to dermatologists, in my experience, and a definitive diagnosis informs the way that I choose to manage my patient, and it basically leads me in my management decision pathway, how to properly treat these lesions. We can advance to the next slide, please. So I won't belabor the data, but again, there is a clinical utility for both dermatologists and dermatopathologists to reduce unnecessary re-excisions in diagnostically challenging lesions with a benign GEP result. Specifically, dermatopathologists reduce recommendations to excise lesions with benign GEP, and dermatologists reduce decisions to perform excisions with benign GEP from the published literature. These three studies contain the data on this slide are already appropriately cited in the actual LCD. If you can please advance to the next slide. So this is an excellent example of why I choose as the dermatologist to actually order go out of my way to order this particular test for my patient. So you can see the central image contains an excerpt from a real pathology report that I received within this year. And we as dermatologists often receive clinically ambiguous reports, and by design, we have the advanced training to recognize cases with diagnostic and treatment uncertainty. And so this is specifically, as you can see here, that in the upper yellow line, I actually write for the purpose of very crystal clear communication with the pathologist or derm path. I write why I chose to remove the lesion. So you can see I had dermoscopic and confocal concern. And then you can see the initial result was a melanocytic nevus compound type with atypical features. And then the actual recommendation in the notes section is to do clinical follow-up of the area. And I want to put everybody in my shoes and in the shoes of a dermatologist. So when I see that, so when I initially have very high concern with the dermatoscope and I use confocal microscopy in this particular case, and the result comes back with what I call a critical mismatch, I have to decide how will I follow up the area. And unfortunately, in this situation, the pathologist did not make it clear. Should I monitor it with clinical photography? Should I do digital dermoscopy? Should I do a deeper shave, a punch, an excision? Those were unclear recommendations, and that's why I chose to, because I thought that this was a melanoma, I chose to order this test. If you can please please advance to the next slide. So why is this important? Please advance to the next slide. Next, oh, perfect, yes, thank you. So this is important because in this slide, I'm showing a workflow and a schematic with many different boxes and lines. This is a representation of the clinical workflow that our team has developed at the Skin Imaging and Technology Center at OHSU in Portland for lesions where we have, or I'm having clinical and dermoscopic concern for melanoma that actually integrates the proper use of 23 and 35 GEP testing. So importantly, you can see that GEP testing is positioned in the schematic for lesions in that first darker kind of light blue box. For lesions with uncertain malignant potential, with different actionable patient management plans that follow a malignant positive GEP result, you can see in red. So in that setting, if we're receiving a malignant result, we're treating the lesion as if it is at least a melanoma in situ, so with a 5 millimeter margin, and then close follow-up of the patient. And then you can see in the green box, if we receive a result that is benign or negative, then we're treating this patient with a close follow-up, and depending on the circumstances, with a smaller shave if we have not removed all of the pigment from that particular lesion. I think it's important to note that physicians do not order molecular diagnostics or other specialty tests if they do not have a plan for incorporating the actual results into their own treatment plans, or if they're unfamiliar with the technology at topic. Just like with dermoscopy and confocal tools, if you do not have a plan how to use the results of those techniques, then a dermatologist will not spend the time and effort to actually perform those clinical moves. And this means that by definition, any physician interested in ordering the test for GEP 23 and 35 should have an anticipation to actually incorporate the result that they receive into their clinical plan, and is familiar with the way that they should actually manage their patient with equivocal or ambiguous melanocytic neoplasm results. And this is our suggestion that's coming out in publication very soon. If you can please advance the slide. And so, yeah, one more slide, please. So I'm going to present just one brief example of using 2335 gene expression profile testing in a patient who is 62 years old. It's a female with a history of non-melanoma skin cancer who had come in for a neck-up exam. And this slide shows two side-by-side images with a clinical photo on the left and a dermoscopic photo on the right of a suspicious skin lesion that's pigmented on chronically sun-damaged skin of this patient, again, close to Medicare age. While concerning, given the dermoscopic perifollicular hyperpigmentation of the skin lesion, I wanted still more information before making a biopsy decision. If you can advance the slide, please. And so this is a confocal microscope. This is a tool that allows us to see the cellular architecture, very close resolution to a light microscope, except it's in the horizontal plane, and it's used by a dermatologist bedside. I'm trained in this and have a PhD in this particular topic. If you can advance the slide, please. And so you can see here that when I use this tool, so first on the left, you can see the dermoscopic image with perifollicular hyperpigmentation, which on chronically sun-damaged skin, and an inability to rule out a seborrheic keratosis, for example, this could be an early melanoma in situ. And so the black and white image on the right is a confocal microscope image. What I want to highlight is that I can see individual populations of cells in high numerosity. They're bright white reflecting, aggregating around the pore or follicle, and there are several of them that have definitively visible nuclei with the bright white cytoplasm. So there are presence of atypical cells aggregating around the follicle, which is typical for follicular tropism in an early melanoma in situ. And so in the context of the concern in dermoscopy and confocal, I removed the lesion. If you could please advance the slide. And so this is what I received in the initial pathology report, was just a benign solar lentigo, absolutely no mention of atypical cells. And I don't fault the pathologist for this. It was a smaller lesion, but at the same time, atypical cells were present, and there was a critical mismatch from my concern in dermoscopy and the tool that I have available with confocal. And due to this critical mismatch, I did decide to order the 2335 GEP test assay. If you could please advance slide. And so, thank you very much. And so given this critical mismatch, I ordered the GEP test. And if you advance to the next slide, please. Okay, yeah. And so this you can see here that the pathologist took their result from GEP into consideration, and then they changed their result, and then it's been validated as a melanoma in situ. So given the critical mismatch, utilizing this test, we were able to have a correct and final diagnosis of melanoma in situ, which I believe is important for the patient to know that they're at a higher risk to develop another melanoma, and also that performing in some settings a shave biopsy would be an inappropriate complete treatment, and even in this case the punch biopsy was not enough, and we had to make a larger excision of this particular lesion for complete and proper treatment. If you can advance to the next slide, please. Yeah, and so moving towards the end of my presentation, the draft LCD DL39345 sets out appropriate guardrails to avoid over-testing. I advocate to include as ordering providers the pathologist, the dermatopathologist, but also a dermatologist. And I hope that my example would delineate why it's important to allow a dermatologist to be able to order this test. All of us, so the pathologist, the dermatopathologist, and a dermatology clinician, we are all specialists trained to identify lesions that meet criteria set out by the LCD. To ensure appropriate testing, the LCD should keep the existing draft language regarding covered GEP test ordered by a dermatopathologist. I'm not going to repeat it here, but I do want to let you know that I agree with the limitations that were set out in that initial draft policy. But patient access to GEP tests should not be limited by access only to board-certified and board-eligible dermatopathologists, as other highly trained treating clinicians like myself can also identify correctly and safely and appropriately lesions that qualify for 23 and 35 GEP testing. I could imagine potentially adding criteria that a dermatologist would need to meet certain criteria to identify lesions of clinical concern, maybe from the clinical history or the dermoscopic image, may be a consideration. If you could please advance to the next slide. So on this last slide, and in conclusion, Medicare already entrusts dermatologists to pick tests before the biopsy. I believe that we can also be trusted to identify appropriate lesions for GEP tests after the biopsy report is made in circumstances where there is a clinical mismatch, as I showed in my example. The draft LCD appropriately covers both MyPath and DiffDX for Medicare beneficiaries based on the published clinical validity that was presented by the previous provider and the clinical utility data. This all aligns with ordering flow at our own particular institution and use of these tests on a daily basis. The only area where I would voice my particular critique is that restricting the coverage only to dermatopathologists may miss the subset of expert treating clinicians, specifically dermatologists, that should also have access to GEP testing to guide patient management decisions. Fundamentally, lesions are appropriate for GEP testing should be accessible and reimbursed for pathologists, dermatopathologists, and dermatologists alike. The test is clearly beneficial for Medicare patients, including my own patients for whom I've ordered this test many times, and I hope that you will consider to add dermatologists to the updated LCD. With that, I'd like to thank you for your attention. And of course, if you could advance to that slide, please, and draw your attention to our educational program that is for providers and for patients. And just to reiterate my interest in melanoma and finding these tumors early and precisely, and 23 GEP and many examples has helped us to make that correct diagnosis and treat the patients correctly. With that, thank you very much for your attention.
Great. Thank you very much, Dr. Witkowski. And with that, we conclude our open meeting today. We thank our speakers and our attendees. And with that, we will stop recording and close the meeting. Have a good afternoon, everyone.